Good morning. I was given this topic to present what atherectomy cutting balloon for ISR and why. And these are my disclosures. We know that in-stent restenosis, especially in femoral popliteal segments, it's a true Achilles heel of peripheral interventions and could be very challenging to treat. And the first part is cutting balloons, and actually it was not easy to find any literature on that. There's a lot of case reports, small studies. The best I could find on that, and talking about cutting balloons, we know that they provide advanced focused pressure on the artery, and they have certain benefits and advantages over conventional balloon angioplasty, such as precision, larger luminal gain, and they are safer, cause less dissections. This is the study that I was able to find, and it was a prospective randomized controlled pilot study comparing cutting balloon angioplasty to conventional balloon angioplasty for in-stent restenosis. And you can see that in terms of acute angiographic outcomes, both were quite comparable and similar in terms of outcomes, except in the duration of fluoroscopy. It was shorter with the use of cutting balloons. When investigators look at the restenosis rates, there were no difference between two devices whatsoever up to 6 months. And there were no differences in ABI and walking distance post-procedure up to 6 months. Conclusion, no difference between those two devices when you use them for treatment of in-stent restenosis in the FemPop segment. What about atherectomy in in-stent restenosis? We know that debulking may be advantageous for in-stent restenosis because of the ability of atherectomy to remove hyperplastic tissue. However, the selection among numerous atherectomy options is commonly driven by anecdotal evidence and physician preference. So there are so many devices out there, atherectomy devices that are available to us. And let's see if we have any data on those devices. And the first one that was studied in a prospective randomized fashion, it was a laser atherectomy device. And the study was Excite ISR. 169 patients were enrolled in laser arm, and 81 patients were treated with plain balloon angioplasty. And if you look at the Babaev stent rates, they were higher in patients that were treated with balloon angioplasty compared to laser atherectomy arm. In terms of primary patency at 6 months, 56% in balloon angioplasty, 71% in the laser atherectomy, and TLR rates were higher in balloon angioplasty arm. That was enough for FDA to approve this device for treatment of in-stent restenosis in FemPop segment. However, if you look at 1 year patency, at 1 year primary patency rates in both groups, laser is still better, but numbers are very low. Look at this, how everything drops down at 1 year. Not impressive whatsoever. In terms of freedom from TLR, at 1 year, again, laser is better, but it looks like it's under 50%, even in the laser group. So you see that patients with in-stent restenosis, even treated with laser plus balloon angioplasty, still the outcome is not great at 1 year. When they did a subgroup analysis, they saw that patients with the longer lesions do benefit from laser more. What about rotational atherectomy? It was studied in a Jetstream ISR study, very small study, 29 patients with FemPop ISR. Again, you see at 6 months patency rate, freedom from TLR was 86%, but at 1 year, only 58.6%. So again, quite a drop. When they looked at the effect on the symptoms of patients, at 1 month, you see that symptoms kind of improve, but at 6 months, almost all patients become symptomatic again. Again, not great outcome. Then there was a JET ISR prospective multicenter study with 60 patients enrolled. And again, when they looked at the freedom from TLR, you see that at 1 year, it's about 60%. They did meta-analysis comparing to the balloon angioplasty historical control and saw that if you use Jetstream with balloon angioplasty, it's better than balloon angioplasty alone. Another modality is OCT-guided atherectomy, which was studied in a prospective single-arm multicenter trial. It was called INSIGHT trial with the use of Panteris device. It was presented at Viva last year. I couldn't find any manuscript to be published. It looks like it's not published. So I was able to pull some data from the company website. And what they did, they put together laser and Panteris device, which is not exactly the ideal way of comparing devices, but anyway. So freedom from TLR at 6 months when you use Panteris was 93%, and you see it with the laser it was 74%. Freedom from TLR at 12 months in Panteris group was pretty good, 89%, and the mean ABI was 0.96. So pretty good results. Again, it's better to, when we get, probably we will get a better idea when manuscript will be published, so we can actually look into details of the study. Nick Shamas put together the slide in JAG that he published. If you look at the atherectomy trials and just compare the TLR rates to the drug-coated balloons, you see the drug-coated balloons definitely win this game. Even they look better than when Viaband stent, cover stent used for in-stent restenosis. Again, this is not an ideal way to compare devices, but that's what we've got. Gandini actually published data comparing laser atherectomy plus DCB versus DCB alone. And at 12 months, patients who were treated with laser atherectomy plus DCB had a better primary patency than patients who were treated with DCB alone. In conclusion, cutting balloons for ISR, very limited data with no benefit compared to balloon angioplasty. It could be helpful in focal non-yielding lesions. Only laser and Panteris atherectomy are FDA approved for in-stent restenosis. Only laser atherectomy was studied in randomized fashion in ISR. Rotational atherectomy treatment of ISR showed better patency and lower TLR compared to PTA, which was historical control. There are small prospective and retrospective studies that showed better patency with atherectomy plus DCB versus DCB alone, but we definitely need randomized trials. Thank you.